Hello, I'm Dr. Kristin Bibbins-Domingo, and I'm here to encourage physicians interested in all aspects of editing and publishing at a major medical journal to apply now for the Morris Fishbein Fellowship in Medical Editing. This is a unique one-year fellowship offered by JAMA to introduce physicians to all facets of editing and publishing in a major medical journal. The application deadline is January 5th, 2025, and for more information, including information on how to apply, please go to jamafishbeinfellowship.com.
From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to our listeners around the world. I'm Dr. Kristin Walter, Deputy Editor at JAMA. I'm joined today by Dr. Albert Su, who is an OBGYN and fertility specialist and an associate professor at the University of Cincinnati. Today we will be discussing a JAMA Insights article titled Ovarian Aging and Fertility, which Dr. Su co-authored with Drs. David Seifer and Eve Feinberg. Welcome, Dr. Su.
Thank you, Dr. Walter.
So can you start by describing the current fertility rate and age at first birth in the U.S.?
Today, we are finding that consistent with declining fertility rates worldwide, the fertility rate in the United States is also declining. And so some of the data that we have is showing that birth rates have declined from about 71 births per 1,000 women in 1990 to 56 births per 1,000 women in 2022. The U.S. Census in 2019 has reported that the age at first birth for women has risen from age 27 in 1990 to age 30 in 2019 as more women are postponing childbearing and the age at which they're both trying to get pregnant and the age that they're having their first live delivery.
So there are many reasons that fertility rates are decreasing, including people choosing not to have children or lack of a partner, economic insecurity, long work hours, lack of pregnancy and postpartum support, and childcare challenges. But as your article points out, ovarian aging also plays a role in infertility. What is the incidence of infertility in reproductive age couples?
You ask a very great question. What is the rate of infertility? So what is the definition of infertility? World Health Organization and what we have traditionally said is that infertility is the inability to conceive after 1 year of regular, unprotected heterosexual intercourse when the female partner is under 35. When the female partner is over 35, we say infertility is after 6 months of trying. The incidence of infertility in reproductive couples has been going up. So 2 years ago, the World Health Organization was reporting that 1 out of 8 couples that were trying to conceive were having difficulty. The World Health Organization updated that number to 1 in 6 in 2023, but a lot depends on your patient population. So we know that there are multiple reports now showing that among female physicians, their rate of infertility is 1 in 4. Our national specialty society, called the American Society for Reproductive Medicine, has recently updated their definition of infertility in 2023 to say that not only is it folks who are trying with heterosexual intercourse, but if you've got a couple where we know the male partner does not have sperm because of genetic abnormalities, something like Klinefelter syndrome or cystic fibrosis, that you don't need to try for a year, we can say you have infertility because we know the male partner does not have sperm to start out with.
That leads to my next question. Can you describe the biology of ovarian aging and the decline in the number of non-growing follicles in the ovary with increasing age?
Very early in human development, we have the bipotential gonads that can become ovary or testicles depending on both genetics and the hormonal milieu. And those bipotential gonads start to differentiate into either ovaries or testicles at about 10 weeks of gestation. Human females have a fixed number of non-growing follicles in the ovary. At 20 weeks gestation, still in utero, the ovary has peaked with 7 million non-growing follicles, each of these follicles holding an oocyte. And at birth, we're down to about 1 million, 1 to 2 million. And at the time of the first menstrual period, women will have several 100,000 eggs, 2 to 400,000 or so. As women get older, the number of eggs is depleting. at about 1,000 eggs every single month. And that depletion starts to accelerate in the 20s to 30s. And so as we describe in this article, the average is there will be roughly 65,000 eggs left in a woman's ovaries at age 25, about 16,000 eggs or oocytes by age 35. And we define menopause as when women have approximately 1,000 eggs. And menopause is when women have not had a period for 12 months. And importantly, there's no effective method to grow new ovarian follicles. And few women will achieve live birth with their own oocytes after the age of 45, despite the best health, despite optimizing their diet, exercise, and even with our most advanced technologies, it's very difficult to help women get pregnant with their own oocytes after age 45.
And your article also states that ovarian aging is associated with a decrease in live births and an increase in miscarriages. Can you discuss why this occurs more commonly in older women?
With older ages, we have a decrease in pregnancies, and even among those pregnancies, there's a decrease in live birth, and there's an increase in miscarriages. And this is challenging because it's multifactorial, and there's a lot we don't know. But we do know that the average rates of miscarriage are roughly 12% in women who are 20 to 29 years old. But then by the time they get to age 40, it's up to a 25% chance of miscarriage. It's a 40% chance of miscarriage by age 43 and a 65% chance of miscarriage in women who are 45 years and older. There are multiple factors that increase the chance of miscarriage. One of the biggest drivers is that as women get older, these oocytes start to develop defects in their mitochondrial structure, in the mitochondrial function. And more importantly, we have meiotic spindle dysregulation. And so as cells divide, there's going to be more abnormal chromosomes. And so these chromosome abnormalities are increasing the risk of birth defects and increasing the chances of a miscarriage or stillbirth.
So in vitro fertilization, or IVF, is a treatment for infertility, but it is less successful in older women. Can you describe the success rates of IVF based on age and why it is less successful in older individuals?
Live birth rates peak at about 40% for one embryo transfer for women under 35 years old. As women get older, those numbers for live birth rates go down. And so as you can see in panel B of our figure, live birth rates are roughly 40% for women 30 to 35. At 35 to 37, that goes down to about 30%. And by age 43, they're less than 5%. There are many sources for this. One is that sometimes you can have the best possible embryo, but the uterus is not ready to receive it, what we call a problem with the window of implantation, or a problem with what some folks will call endometrial receptivity. We know that there are other factors that may increase the chances of miscarriage or not having a live birth, whether it's issues of preconception health, uncontrolled diabetes, uncontrolled medical problems. It's very important to optimize maternal health prior to conceiving a pregnancy.
So let's move on to strategies to address infertility due to ovarian aging. Can you start by discussing the importance of education and societal support?
My hope is that more primary care clinicians ask their patients about their interest in parenthood and future childbearing. And as appropriate, because not everybody wants to have children, but for those who do want to have children, to educate them about ovarian aging and the reduced likelihood of pregnancy with advancing age. On a broader societal level, there are many barriers to family building in the United States. We know that there are unfortunately gender disparities in parenting and household responsibilities. We know that there are insufficient maternity and family leave policies. We know that there's a limited availability of childcare options. And for many careers, there is often a lack of flexibility to accommodate pregnancy and parenthood. And because of that, many people, they will delay childbearing while they're pursuing professional development because Unfortunately, the peak years for professional development and career development coincide for women with the peak childbearing years.
The cryopreservation of oocytes and embryos may allow women to achieve pregnancy at older ages. Can you describe the process of oocyte and embryo cryopreservation?
Oocyte cryopreservation is an option that allows women to achieve pregnancy at older ages. When women are interested in oocyte cryopreservation, we call it egg freezing, then they will take injectable medications to stimulate their ovaries to recruit multiple mature follicles. Under anesthesia, oocytes will then be surgically removed and frozen. The surgical procedure involves anesthesia so the patient's comfortable, and this is, in almost all cases, performed under transvaginal ultrasound guidance. And so essentially what we do is we go into each ovary with a needle, into each of those follicles, and bring out 5, 10, 20, maybe 30 eggs. But these eggs are retrieved, and for women who are freezing eggs, our embryology lab is able to freeze the eggs for the future. At a future date, those eggs, those oocytes can be thawed and then fertilized with in vitro fertilization. Specifically, after an egg freeze, those eggs, after thawing, will be injected with sperm to fertilize those eggs with that sperm, and then those resulting embryos can be transferred to the uterus, or those embryos can be frozen, cryopreserved for future use. And there's no known upper limit for the length of time that oocytes or embryos can be frozen. It is very clear that oocyte cryopreservation is more successful at achieving pregnancy than delaying childbearing and then planning for IVF at a much older age. When eggs are retrieved and frozen, they are forever young. If you have a 30-year-old egg and you freeze it, it will always be considered a 30-year-old egg with an excellent chance of pregnancy and live birth, and with a low chance of miscarriage, stillbirth, pregnancy complications, and a low chance of birth defects.
How do you counsel individuals about the success rates of achieving pregnancy using egg or embryo cryopreservation at a younger age versus waiting and doing IVF without cryopreservation at an older age?
There's increasing data showing that egg freezing at younger ages is much more successful than at older ages. One paper was looking at the cost effectiveness of egg freezing for those desiring one child, and that to plan oocyte cryopreservation at age 33 and then thawing those oocytes at age 43 and then making embryos and having a live birth, it decreases the total cost per patient from about $60,000 to about $30,000, while at the same time it increases the likelihood of having a live birth from 50% to 70%, compared to just delaying for 10 years and then planning for 3 cycles of IVF at age 43.
Thank you so much for sharing your thoughts with us about this interesting and important topic. That was Dr. Albert Su, and I'm Dr. Kristin Walter. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.